Welcome everybody to this Facebook Live here with OrthoVirginia. I'm Dr. Corey Resnick. Just wanted to chat with you guys about hip and knee arthritis, sort of walking you through sort of from, my hip or my knee hurts through surgery and then at the end answer any questions that anybody has. So starting out, I had no disclosures to talk about. And just sort of the roadmap for this talk, I'll give you guys a little introduction for myself, my backstory, where I trained from, and then sort of get down to some of the basics. What is arthritis? I think there's some people come in and they don't exactly know what it is, or they sort of hear about it. So we'll chat about that. We'll talk about, once we know that we have it, what can we do? All the non-surgical things that we can do and help you out with, as well as, surgery for when those non-surgical things stop working. Talk about what patients have to do to sort of get themselves from clinic to the OR, what a hip or knee replacement involves, and the recovery process. I'm Corey Resnick. I did my sort of going from the beginning. I went to college in upstate New York at Colgate University. I really enjoyed my time up there. Went to medical school a little closer to here up in DC at George Washington University. I did most of my orthopedic training up in New England at Dartmouth, and I did my fellowship training where I did 1 year just focusing on hip and knee replacements up at VCU. I live up in Richmond with my wife, 2 young kids. I have a 1-year-old and a 3.5-year-old, and we have an 11-year-old yellow lab named Stella. I'm originally from New Hampshire, and just, I'm a big sports fan, New England sports for the most part. So getting into it, what is arthritis? And arthritis is sort of disease or damage to articular cartilage. And articular cartilage is what lines your knee joints. You have them in your hip, you have it in your knee, you have it in your hands, you have it in feet, and damage to that is arthritis. And so when you have arthritis, it sort of leads to this response within these joints, and the cartilage itself gets flooded with water. You have decreased organization of that structure. You can get thinning, fissuring, and eventual loss of actual thickness of that cartilage. And this happens in various stages. And on the right hand of the image here, it's a knee arthroscopy where they sort of flood the knee with water, and you can see up at the top what normal cartilage surface looks like. It's white, it's smooth, it's kind of shiny. And then when you have damage, it's gone, and basically you're kind of left with bone at that point. So that's where that sort of bone on bone sort of phrase comes from. Some secondary changes of arthritis within joints themselves. There's synovium, or this tissue within the joints themselves. It's kind of a pain generator when it becomes inflamed, which is associated with arthritis. It can become more vascular, become thicker, and that's something that we see more on the operative side, or if we were to get an MRI. The bone itself shows a lot of changes, and that's primarily what we see and what we talk about in clinic is the bone will remodel. It will become more sclerotic or become more dense or white on x-rays. You can get osteophytes, which are additional bone spurs that come off the end of the bones, and you can eventually get deformity. You can also get these cysts, which basically form below the surface and are typically fluid-filled. So if we think that you have arthritis or we want to know what's going on, we diagnose it with various different aspects. X-ray is the most common thing that we use. Most people who I see come in with hip or knee pain, we're going to get our x-rays to see if you have arthritis. This is just a knee, for example. There's various stages. We typically use this Kellgren-Lawrence grading system where it rates knee pain, or not pain, but severity of arthritis from a 0 to 4. 0 and 1 are fairly normal. 2 is a little bit more narrowing. 3 is a little bit more narrowing with some osteophytes. And 4 is all the way to the right on that top image, and that's where you start getting bone on bone and a lot of secondary changes. If there's somewhat of a confusing picture, or we think maybe there's more cartilage damage than what we can see via evidence on x-ray, sometimes we'll get an MRI, but that's not the best tool in most folks to sort of really diagnose arthritis. So you have arthritis, now what? The first thing that we do is we kind of throw all the things at it that are not surgery. If you can control your pain with these modalities, it's a far easier and less risky proposition in terms of controlling your pain. And so the first thing is activity modification. If it hurts when you do one thing, see if you can live without doing that thing. From medication standpoint, Anti-inflammatories, if you can tolerate them, are kind of the best thing. Oral anti-inflammatories, things like Aleve, ibuprofen, various prescriptions that we can write, as well as topical anti-inflammatories, things like Voltaren gel or diclofenac gel is the generic form. Other medications, injections, play definitely a role in trying to help with the pain process in arthritis. And all of these are aimed at decreasing inflammation, which is sort of the main pain generator in arthritis. So we can control the inflammation. Often we can control people's pain, at least for a while. Therapy can be important too. You can do outpatient physical therapy. There's home exercises that we can give you as well. And doing things that are low impact activities like swimming, elliptical, cycling, things like that are all very joint friendly. Weight loss is beneficial, and bracing as well. There's certain specialized knee braces in particular that can help offload certain compartments of the knee that might have more arthritis than the other. So who needs a joint replacement? And sort of it's somewhat semantics, but I like to say it's somewhat of a thing that I like to talk with people about. Nobody really needs a joint replacement. I like to tell people that I offer something that I think people can benefit from, but I'm not a cardiologist. I'm not, an oncologist or a cancer doctor, in the sense when they tell you that you need a procedure or a test, it's very much a shared decision-making progress for who needs a joint replacement surgery. And it's more so if your pain is persistent and impacting the things that you want to do, and you're interested in undergoing surgery for a more permanent fix to the problem, then you could certainly benefit from this, and it's a very successful surgery. So my sort of simplified criteria that, when I see folks I'm working through in my head is you have to have advanced arthritis. If you don't have advanced arthritis, having the joint replaced is probably not in your best interest. If you have pain that's interfering with your daily activities, it's bothering you not, once or twice a month, but it's something that's bothering you every day, you're thinking about it, it's waking you up at night, and you've tried all the things that you can do that are still not surgery, and you're still having persistent pain that's bothersome despite those other modalities. So expectations around surgery, I think, are very important. This is probably my favorite slide on here. And one of my mentors used this analogy that I thought was very helpful. You don't have to totally understand cars to get the gist of this, but understanding the expectations of surgery poorly is a major reason for postoperative dissatisfaction. And that's obviously something that we want to avoid. And so I like to tell folks this is not going to be the hip or the knee that you had when you're 20. Joint replacement surgery is primarily for pain. Often people do get some increased range of motion, but that's not the primary reason to have the surgery. And, if you weren't able to do something beforehand, like running or kneeling, things like that, you may not be able to do it afterwards. It's primarily for pain relief that's bothering you every day. And so my favorite analogy is when you were born, your knees or your hips were Ferraris. Sort of at their core, they're agile, they can go side to side, quick, they have a certain capacity for a certain level of activity. And right now, however old you are, that's how old your Ferrari is. It's getting older, it's rusting, the brakes are gone, the suspension's out, and you're ready to bring it into the shop. The shop's not a Ferrari dealership. Basically, we're a Toyota dealership, and I can replace that with a Toyota Corolla. It's reliable, it's dependent, it gets you from point A to point B, but it's not going to be the same. So if we get to this point and we're sort of on board to have surgery, there are certain things that you have to do to sort of get yourself in the best position to do this in the safest way possible. One is pick a location. So I do most of my surgeries at these two locations, either Tri-Cities Hospital down in Hopewell or at the operatory over in the OrthoVirginia operatory in Westchester. So first thing is get medical clearance. So pre-admission testing at the hospital, if you're going to be over there, or lab work that I ordered. Subspecialty clearances. If you see a heart doctor, a lung doctor, a kidney doctor, I like folks to quit all nicotine products prior to having surgery and get your weight down to a level where your body mass index is less than 40. We get you set up with some outpatient physical therapy to begin somewhere between 5 and 10 days after surgery. And I like to see everybody back a week or two before surgery to review these labs, go over the risks, consent, show up sort of a model of the things that I do, and make sure everybody's comfortable prior to proceeding with surgery. So sort of the basics of what a knee replacement is it's typically 3 components. 4 if you include the plastic liner. But basically you have a C-shaped cap that sort of overlies the femur after making several cuts that you can see on the right side. There's basically cuts on the top, at the end, on the bottom, and then these oblique chamfer cuts. And then you make a flat cut on the tibia. And basically what you do is you sort of prep those surfaces to match the shape of the components that you end up putting into the bone. Tibia, or the bottom component, goes into the tibia, and then I typically cement my components, and so they go into a layer of cement that gets immediate fixation, and then the femur gets capped. There's a plastic piece that goes between the two, and then depending on the state of your kneecap or the backside of your patella, I typically decide in the operating room whether or not I feel like that needs to be resurfaced. I don't resurface everybody's patella. Hip replacement, it's a little bit different. So there's definitely more bony cutting in a hip replacement as we take the top part of your femur and we cut it out. The part that was articulating and that was bone on bone, we cut that out. And what we do is we sort of ream, it almost looks like a cheese grater on the side of your pelvis, and basically put a cup into the pelvis. And then we use sort of increasing sizes of a broach to make holes inside the top of your femur to match the size of the component that we put down into the femur. And then we put a ceramic ball and a plastic liner in the cup, and that becomes your new hip joint. And on the right side, there's sort of 3 common ways to do a hip replacement. I typically do an anterior approach to the hip. In certain situations, we'll do a posterior approach, but the majority of my hips, I do via an anterior approach. So you've had surgery, what does recovery look like? And so typically I see people back at about 2 weeks. Make sure that the incision is looking good. 6 weeks, sort of a clinical check to see how you're progressing with therapy, and 3 months, and then 1 year. Full recovery, I tell people, takes between 12 to 18 months after either of these surgeries, and that usually raises people's eyebrows. But the biggest recovery is within the first 3 months. So, as much as 80-90% of your recovery is shifted towards the front end of things. And so there's still recovery. Like when I see you at 3 months and I see you at a year, there's definitely an improvement that occurs. It's just not as big as that improvement that comes from day 0 to day 90. Surgery itself, people are either going home same day or spending the night in the hospital and leaving the next morning. And typically I tell people that this is a marathon, not a sprint. And so you're going to have days that are worse than the previous day. But overall, when you look back from a week to week or a month to month basis, things should be moving and trending in a positive direction. So post-operatively, from a pain standpoint, I do write people a prescription for a narcotic afterwards to help. I typically write for an anti-inflammatory medication as well as Tylenol. I kind of tell people, I don't necessarily tell people that surgery is pain-free, but we try to make it as pain-less or decrease as much pain as we can. But certainly I sort of jokingly tell people, you may not like me so much at 2 weeks when you come back to see me, but hopefully things are trending in the right direction for you. My preference is to do people's surgery under spinal anesthesia. I think that helps with your recovery. It requires less sort of anesthesia medications, get you up and moving a little bit faster with good pain control. Most people are doing PT for 6 to 8 weeks, a couple times a week, and starting this 5 to 10 days after surgery. And PT is important. It's especially important after knee replacements to get that strength and range of motion back. But after surgery, your weight bearing is tolerated, range of motion is tolerated for knees. Weight bearing is tolerated, and via an anterior approach, I tell folks to just sort of avoid extremes of motion for their hip, but no specific restrictions in terms of range of motion. And everybody gets up and walking the same day of surgery after their spinal wears off. So I appreciate you guys taking time out of your day, listening to me chat for a while. And I'd like to open it up for any questions.
Thank you so much, Dr. Resnick. We do have some questions that have been sent in earlier. We will also be taking some questions that are sent in now. We will answer as many questions as we have time for, but we won't be able to get to every question. So the first question that we have is, how often can I get a shot in my hip or my knee?
Good question. So the short answer to that is every 3 months. And so I like to sort of limit folks to about 3 shots per year, but truthfully, it's usually about every 3 months. We're willing to do that with a steroid. Certainly, we do use some injections like gel injections specifically for the knee, and that's something that's more every 6 months as opposed to every 3. But typically with a steroid injection, which is most commonly what we do in clinic, is every 3 months.
Thank you. Are there any exercises that help with knee and hip pain? Like, would walking or yoga help with that?
Certainly low impact exercises I think can be helpful for both, sort of within tolerance. I don't want people to be, torturing themselves to do certain things just because, someone said that it could be helpful. But I think that exercises in the way that are low impact can be really helpful. So walking is good, but sometimes walking on hard surfaces or uneven surfaces can be bothersome for hip and knee pain. So it might be walking on flat ground or walking on grass to take some of that stress off of those joints. Doing things like swimming, cycling, elliptical can all be a little bit more joint friendly from my experience. Yoga is not a bad thing to do at all, but sometimes those activities have to be modified to make it so it's something that you can do.
Thank you. Can you sleep on your side after hip replacement surgery?
Yeah, so I have no issues with people sleeping on their side after hip replacement surgery. So unless there was, some type of abnormal situation, but from an anterior approach, I don't have an issue with it at all.
Thank you. How long do the implants last?
Yeah, so nowadays with sort of the bearing surfaces that we have, there's far less of a problem of the implants actually wearing out due to intrinsic factors within the implants themselves. So the hope is that you get it done and you get it done once. Obviously if there's, a situation where you have arthritis and you're young, maybe you're in, your 40s or 50s and, you certainly hope to live for the next 40, 50 years. It's possible that things may have to be revised in the future, but there's certainly not a set end date to these implants. I usually tell people there may be, like, in people's lives, a 1% chance of something happening to the implants every year, whether it be infection, whether it be loosening, whether it be instability, things like that. But there's no set time point when these wear out. It used to be that people would sort of expect, in the 10 to 15 year mark that the plastic components would wear off. That's not the case anymore.
Thank you. Is arthritis permanent? Can it be cured or only treated?
It's a good question. So once the damage is done to the cartilage, we don't have a great way of fixing it. And so it becomes mostly symptom management after the damage to the cartilage is done. There are some cartilage procedures that can be done in people who are younger typically, but it's usually for small areas without sort of widespread damage to the cartilage. So something small. However, that's the minority of cases, and typically in folks who are quite young. And the majority of people who have arthritis, they have it in larger, broader surfaces in their joints. And so in those situations, we don't have a great fix to that problem. And so sort of it's symptom mitigation, managing people's pain until, or if it becomes to a point where it's not well controlled, and then joint replacement is certainly a very reasonable option at that point.
Thank you. Does arthritis flare up in cold weather or warm weather?
That's a good question. A lot of this is sort of more anecdotal, I think, than anything else. I will say in honesty, being down here in Virginia, I get a lot of folks who come in over the winter and say that, everything was fine until, we had a 20-degree day. I did most of my training up in New Hampshire, where it was a bit colder up there and a lot more snow. I truthfully didn't see those patients as much as I do down here, so I'm not totally convinced about the cold-warm aspect of it, but certainly people do have an association of that.
Thank you. Are there any diets that are better for arthritis?
So sort of low inflammatory diets, I think, are better as a whole. I don't have a specific diet that I necessarily recommend, but certainly, in my training, we talk frequently about some remedies and not some over-the-counter adjuncts that people can use in their diets, like turmeric or tart cherry juice that people can take that are a little bit more natural, as opposed to like a prescription for meloxicam or Tylenol or ibuprofen that are anti-inflammatories that are more natural, that there's actually some literature behind and supporting.
Thank you. If you have arthritis in your knee or your hip, does waiting too long to have the surgery impact the outcome?
The short answer to that is no. So it's something that if you have arthritis, you're typically always going to have arthritis until a surgery is performed to sort of change the situation in the joint. And so it doesn't matter whether you have the surgery, if you can tolerate the treatments to make your pain level something that you can live with. The sort of more detailed answer to that is if you wait long enough, sometimes in that slide that I showed, you can get some deformity of the bones and the joints when your arthritis gets really severe. And it doesn't mean that your outcome is going to be worse or the surgery is no longer possible. People ask that frequently. It just means it might be a little bit different from a preoperative planning standpoint. We might have to use different implants or use a different approach at the surgery because the severity is more severe.
Thank you. What's the difference between the anterior and posterior approaches to hip replacement? And does one heal faster than the other?
So the anterior approach is more sort of a muscle splitting approach. You sort of go more sort of in an interval between two muscles. And so you can quite literally get all the way down to the hip joint around sort of the proximal or top part of the femur without having to cut muscle. And so there are some people who believe that may have some advantages in terms of pain. I think the literature would say that probably the approach that the surgeon is most comfortable with is truthfully the one that is the one that they should employ and is the best thing for the patient in the long term. I think that both are viable options. We definitely did both of them in my training. I'm very comfortable doing both of them. I like the ease of using X-ray during the procedure for an anterior approach. And so you leave the room, you know exactly what your parts look like in the position that they're in before you leave the room. And so maybe some advantages to an anterior approach on the short end of things. I think in the long run, there's probably no differences between the two as long as the parts are put in correctly.
Thank you. How do you decide that the pain is enough and start looking at replacement?
So a lot of that is discussions that we'll have in clinic and sort of seeing, what things you've done, what things you're able to do. So we've talked a lot about anti-inflammatory medications. Not everybody can take those. And so sometimes it's limited in what people can use to sort of help control their pain. And so that list that I showed is sometimes shorter in certain folks than it is for other folks about the options that they have to help control their pain. And so level of pain that you can tolerate prior to start looking for a replacement is truly a personal decision. It's got to be sort of a shared decision-making model between the two of us. Is it like impacting the things that you want to do? Is it waking you up at night? Does it bother you every day or just, every couple of months? And that's all things that we can talk about in clinic and find sort of, between the two of us, what's an appropriate direction to go in.
Thank you so much, Dr. Resnick. That's it for questions today. Would you like to close?
Yeah. So thank you everybody for logging on and listening. Hopefully this was somewhat educational and beneficial for some of you all, and look forward to seeing you guys in clinic.